Okay, so this chapter is going to talk about the economics of the hospital industry. A little bit about the history of hospitals first. So in the 19th century, hospitals could be fatal places to go for medical care. There is actually a higher mortality rate in the hospital than at home. So it makes sense for people to die at home rather than to die in the hospital, because if you die at home, you don't need to pay. But if you die in the hospital, you have to pay, and there's higher likelihood to die in the hospital. However, in late 18th, in the late 1800s, innovations have helped lift hospitals' reputation due to technology advance in a lot of different perspectives. So this creates increased demand for hospital surgeries, and it also leads to increased need for more hospital resources. In the 1946, the Hill-Burton Act increased the number of hospitals in the United States. Congress starts giving more money for building hospitals. Any hospital receiving money had to provide free or low-cost care to the poor. So this results in more hospitals and more hospital beds. However, if you look at the graph, you can see that number of hospitals or number of hospital beds starts declining from 1970s, okay? And actually number of outpatient visits have been steadily increasing. And if you look into this right graph, length of stays in the hospital is also slowly decreasing. So average length of stay was 9 days in 1946, but towards the end of 2010, it's decreased to probably 6 days. Okay. So how do we explain this decrease of inpatient care while increase in outpatient care? Some hypotheses think that it's because of technology innovation. Technology advances have reduced the recovery times, so people can recover faster and get out of the hospital faster. Another reason is insurers increasingly design hospital payments to incentivize shorter hospital stays. So for example, before 1986, the payment system is called a fee-for-service system in the Medicare payment. So for example, someone does a surgery, then Medicare pays hospital the money for the surgery, and then someone does some checking or some recovery procedures, the hospitals would get paid for every new procedures that they perform. But in 1986, Medicare decided that they're gonna pay hospitals for a fixed fee based on diagnosis at the time of admission. So when you admit this patients, you give a diagnosis, and I'm gonna group them into 600 or 900 different codes. And as long as your code is, let's say 3, then any patient who belongs to code number 3 will get the same amount of payment. Okay, so that means hospital treating the same code patients. So every patient that come in with the same diagnosis code will make the hospital receive the same amount of money from Medicare. Okay, so if the hospital already know that, okay, this patient is code number 3, and this is the fixed amount of money that Medicare is going to reimburse for me by treating this patient, then when I know my revenue is fixed, I cannot maximize my revenue, but I can minimize my cost. So as a hospital, I want to minimize my cost. I want to make this patient leave the hospital as soon as possible. I also want to just minimize all the other procedure costs. I'm not going to do anything unnecessary because I'm not getting any extra money. Okay, so this payment system have make the trend towards increased outpatient visits and decrease the length of stay of an inpatient visit. Okay, so I'm going to show you an example here. Okay. All right. Okay, so this is several different codes that we have mentioned. So for example, one of the very common procedures that were done in an inpatient visit is delivering babies. And some mothers will choose to deliver babies through a C-section. Okay, so if this is a C-section delivery, then I will group them into C-sections with sterilization and without sterilization. Okay, and then with sterilization, I'm gonna divide them by yes with major complications. So MCC is major complications. And then the second one is CC, which is complications. It's complications, but not major complications. And then the last one is no major complications, no complications, which is just a normal C-section with sterilization. Okay, so then these mothers or these patients will be grouped into 783 if it's a C-section with sterilization with major complications. Okay, or 784, which is C-section with sterilization and with complications. And then 785, which is C-section with sterilization without major complications or without complications. Okay, so then based on this code, the hospitals will know that there will be a fixed amount of money that Medicare is going to reimburse for the hospital. Okay, because this part, the mother herself is not paying any money. The hospitals will only get money from Medicare, and Medicare will give a fixed amount of money based on this code. Okay, so let's say two patients come in, both of them are C-section with sterilization with major complications. Then these two patients will both be coded into 783. Now, if one patient stays for 5 days, another patient stays for 9 days, the hospitals will still get the same amount of money from Medicare. So then the hospital would want more mothers who stays shorter instead of more mothers that stays for longer because they're getting the same amount of money. Okay, so this is the fixed payment system that incentivizes decreased length of stay. Okay, so this is a graph for hospital stay between 2000 and 2009 across different countries. So here, the country that has the highest or the longest average length of stay is Japan, even though Japan also improved a lot from 2000 to 2009. We can see that in 2000, an average patient stayed for 25 days. But in 2009, an average patient stays for 18.5 days. The red bar here is an average of OECD countries. These are mostly developed countries. So we can still see a clear improvement from 2000 to 2009. Okay, so next we're going to look at the relationship between hospitals and physicians. There are different modes of hospital-physician relationships. There is physician workbench. In this mode, physicians do not directly get employed by the hospitals. So this is the mode for majority in the United States. In the UK system, hospitals directly employ physicians. While in the Japan system or some part of US, some physicians can own their own hospitals. So there are trade-offs between these different modes because these are agency problems. Remember when we talk about agency problems as an economist, we are talking that different people maximize their own utility function. And their utility function might not align with each other, which means that there might be different incentives. Okay. So for example, physicians' loyalty to hospital or to the patients is a trade-off. If they are more loyal to the hospitals, they probably want to make more money for the hospital. If they are loyal to the patient, then they probably will try to maximize the patient's health and to minimize the patient's cost. Doctors without connection to the hospital may overuse the hospital resources because those are free. Okay. There is a positive volume outcome correlation between surgical mortality rates and hospital volume. So surgical mortality rates is lower for hospital volumes that are larger. Okay. How do we think of that? How do we think of bigger hospitals having a smaller surgical mortalities? Well, there are different hypotheses. The first one is volume leads to outcome. Okay, we call that learning by doing hypothesis, that if there is a high volume, physicians can learn a lot. So that leads to better outcomes. You can also explain this correlation in the opposite way. So you can think of it as a selective referral hypothesis, which is that better outcomes leads to higher volume because people select themselves into better hospitals. Okay. All right. So I would think of this as also another perfect example of correlation doesn't mean causation. That you see a correlation between volume and mortality rates, but you don't know which one is the reason and which one is the result, or there might be both ways. So it's important to figure out which one is the reason, which one is the result, if you want to do something about it. Okay. Does hospital experience or physician experience matter? Should you prefer having your surgery with an experienced physician or in an experienced hospital? So this sounds like obviously yes, but we want empirical evidence about it. So this paper in 2000 finds that hospitals with more surgical experience have fewer complications than physicians with high experience. So this finding makes sense if teams of medical workers collaborate on surgeries. So individual physicians will experience so physician experience is less impactful. More than half of all surgical errors actually occurred outside the operation room. Okay, so the next part, we're going to look at the relationship between hospitals and hospitals. Okay, so basically hospital industries. Okay, we think of the hospital industry as a differentiated product oligopoly. Okay, when we talk about monopoly, we're talking about one player in the industry, but obviously we have many hospitals. So this is not a monopoly, but an oligopoly. Different hospitals are providing differentiated products. So it's a differentiated product oligopoly. There is strict barriers to entry because opening a hospital, you need buildings, technology, staff, administration. You need to get approval from regulations. So that strict barriers to entry always will lead to a limited amount of players, which we call firms. And this often leads to oligopoly. Services provided by each firm are not perfect substitutes, which means that some things you get from one hospital, you might not be able to get it from another one. Okay. We have an index, HHI, to describe how concentrated is an industry. Okay, so HHI equals to the summation of SI square. SI is the market share for one firm. So think of if we only have one firm in this whole industry, there's only one player, everyone has to go to this one single hospital, there's no other hospitals, so then SI is 100%, okay, because this hospital takes up 100% of the whole industry. Okay, so then if SI is 100%, then 100% square is 1, okay? So then this is the first case that if HH1 is closer to 1, then it means fewer firms in the market, okay? That means this industry is highly concentrated in one firm. All right, then we have the other extreme, which is HHI closer to 0. So this means that we have lots of hospitals, and each hospital takes up, let's say, 1%, 2%, or even less than that share of the whole market. So that would mean that this industry is not highly concentrated. In fact, there are a large amount of firms in the market. Okay, so FTC and DOJ, they characterize an industry that if HHI is larger than 0.18, then they are concentrated. If it's larger than 0.25, it's highly concentrated. Okay, and HHI for US hospital market is actually 0.33. So that concludes that US hospital markets is highly concentrated according to this this rule. All right. So that leads to a limited amount of competition between hospitals. But that is not completely because of barriers of entry. It also because of insurance. So first of all, prices is not transparent. When you receive a medical bill, you feel so shocked that there are so many different prices on one single bill, and all you get is probably just a blood test, right? So prices are not transparent. There are some things that you pay out of pocket. Some things are belongs to the insurance company. The insurance company pay a certain amount of that, and some part of it just get waived. You don't know where those money goes. So prices are extremely non-transparent in United States. Another problem is there is a moral hazard for insured patients. So think of moral hazard as that when a patient has insurance, then he or she might get more unnecessary healthcare than he or she actually need. Or think of he or she might not be as careful when he is roaming around. He would think about, oh, if I get injured or if I get sick, I have insurance, so I'm not going to be taking care of myself so well because my insurance covered it. Versus if you don't have insurance, you might think I cannot get sick because I don't have an insurance. So so all of these moral hazard plays into the limited competition between hospitals. Another reason is that government sometimes will set price for certain products. Emergency nature of healthcare means that patients are unable to search for the best or cheapest hospitals. So think of think of when you want to buy an Instant Pot, you go to Amazon or some websites, there are 10 different products and you can see which one is cheaper, right? But how many of you compare prices of a blood test between hospitals and find the one that is cheapest? This is not something that is so transparent, or hospitals don't usually compete on price. So if that is not possible or that is not convenient, then hospitals will compete on quality. Okay, so if a hospital is known for better quality, they try to provide better quality healthcare. They try to provide the most fanciest technologies that is on top of the market. okay, then this kind of quality competition will actually increase the inpatient stay cost or increase the medical bill instead of bringing the bill down. Okay, so this medical arm race hypothesis speaks to that hospitals compete on quality by adopting the best medical technologies available to appeal physicians and their patients. And this competition results in a race for each hospitals to have the best medical technologies. And this may cost over consumptions instead of the most efficient, cost-effective solutions for healthcare. Okay, so MCOs in 1980s tamped down the medical arm race. Is hospital competition good for patients? Typically, we think yes. Competition is, in most cases, nice. That because it can improve quality. As long as patients can vote by foot, okay, then there can always be hospitals that provide a better quality or a lower price that draws more patients if patients can choose. But under certain conditions, competition might adversely affect patients' health. This is also because the industry is very complicated. So for example, some findings find out that impact of hospital competition on all non-rural Medicare patients in the US for acute myocardial infarction. I found out that more competition leads to lower costs and lower mortality rates. But another study in Los Angeles County, they find that more competition actually worsened the mortality rates in this part of the county. Okay. All right, so that's the part of competition. Now we're gonna look at hospitals' profit system. So we have for-profit and non-profit hospitals. 20% are publicly run, but most of them are nonprofit. So in 2009, 75% of the private hospitals are, even though they are private, they are still organized as nonprofit. Okay. So there's trade-off between for-profit and nonprofit. The benefit of nonprofit is that they are exempt from taxes. If there is lower tax or no tax, then prices will be lower. Okay. It also incentivizes people to donate money because donors can receive a tax reduction. The drawbacks of nonprofit is that it cannot sell stock and it cannot distribute profits to the owners. There's restricted to certain charitable activities. Okay, so when we ask the question of why do nonprofit exist, there are a couple of theories. We're just gonna go through them quickly because this is not the most important part of this chapter. The first one is called altruistic motive theory. This theory says that some entrepreneurs, they prefer altruism over profits. Okay. The second theory is called government failure theory. This theory believes that government is not doing a great job in some part of the market or the economy. So then nonprofit plays a role in filling that gap, in making up that part of the market failure. The third theory is called asymmetric information. Donors trust nonprofits more with money. The fourth theory is called nonprofits are for-profits in disguise. So they think that nonprofit is just a way to profit, okay? The profits are distributed as higher wages or non-monetary benefits. And there are mixed study results for this part. Okay, so then the last part, I want to talk about the relationship between hospitals and payers. Prices vary greatly across hospitals. This is a mystery in in this industry, because a lot other industries doesn't have this kind of situation. So for example, according to public price lists or charge masters, the cost of a chest x-ray in 2004 ranged between 120 and 1,519 across 7 California hospitals. So if you ask, is there super fancy chest x-rays and super shitty chest x-rays? The answer is probably not. So what makes up such a huge price differences? Okay. But in reality, buyers, both the insurers and the patient, rarely pays that much. Okay. People rarely pay the largest number on that medical bill. So we want to look into this, that there is a process of negotiation, both private and public, between the hospitals and insurers and the patients. So rates usually vary with the relative bargaining power of hospital and insurer. If the insurer has higher bargaining power, then insurer can pay less. Okay. If the hospital has higher bargaining power, then they charge more. The same hospital may receive different rates from different insurers. So for example, a hospital faces private insurers and also Medicare, Medicaid. So going back to our example of C-section. So if a mother comes in with a Medicare insurance, then hospitals get a fixed amount of money from Medicare, which is predetermined. But if a mother comes in with Medicaid or a private insurance, then the hospital might be able to get different things, different amount of money. Okay, so that's also a part of the prices differentiation. This is another graph for the chest X-rays. About 7 different hospitals in California. Another part of this price that we want to mention is that there is uncompensated care. So where do they come from? They come from a mandate called last resort laws. So last resort laws says that if a patient shows up in an emergency room, whether this patient has money or not, hospitals have to treat it. This is quite different from my experience in other countries. In a lot of other countries, people don't get treated if they cannot pay for the service before they get treated. So what happens to the patients who get treated but are not able to pay for the fee after that? We call those uncompensated care. And when there are care that are not compensated, someone has to pay for it, right? Because eventually, even though this patient doesn't pay for the service, hospitals, let's say physicians or nurses, still have to get their salary. So we call that cross subsidization or cost shifting. So eventually, richer patients, they pay a little bit more than they are supposed to pay or they are receiving, so that the extra money can cross subsidize the loss that hospital treats patients who are not able to pay for it. In the US, reimbursement rates much higher for private insurance than for Medicaid and Medicare. Okay. This graph is the last graph of this chapter. It shows the collection ratio at California hospitals by insurance type in 2005. So what is collection ratio? Collection ratio is defined as the total revenue actually collected by the hospital divided by the official charge master bill for the procedure performed. So this is the ratio that the hospital actually get from insurance, that out of the biggest number that we see in our medical bill. Okay, and the question is, do they get 100%? Of course not. For private insurance, they get 38%. This is already the highest. Okay, for no insurance, they get 29%. For Medicare or Medi-Cal, this is the Medicaid of California, they get only 23 and 27%. Okay, so that is the end of chapter 6.